All right, here's a chart there, and this is just
That's
showing
what I needed.
identifying the different type of burns.
Did it have a chart number?
It probably is incorrect.
Oh, okay.
The figures, and so we'll apologize for that you see in the PowerPoints, or if it say box so and so, you are going to have to find that within your chapters because we have updated all of the reading pages and the objectives with the new edition, but we did not make changes to our PowerPoints. So if you see this figure 53, that's from the 5th edition. So you probably should be able to find it still within that number of pages of reading. And it's just showing those. So don't want to confuse you. Don't think that'll be a problem with your test question. But we'll go with the CAB. And just be mindful of when you're taking NCLEX or whatever and how they may pose the question. I can't really say, because I think they will go with the American Heart Association. So just read the question and make sure you understand it. So you still could get it possibly incorrect. Everybody got me there?
Yep.
All right, so therapeutic management, emergency care priorities, stop the burning process, right? We want to assess the victim's condition, cover the burn to prevent contamination. How do we possibly handle a scald burn? Scald.
Okay. Like a scalding?
That's the hot water.
Yeah.
Put it under cold water, but you don't put ice on it.
Say that again. Somebody say it. Just one person at a time. You can speak louder.
Cold water, but don't put ice on it.
Right. Submerge under cold water. No ice. Therapeutic management, continued airway maintenance, and what's critical in the first 24 hours is replacing that fluid loss. They become very, very edematous, right? And so that's why we do know with the chest up, that inhalation burn or whatever type of burn they've had, they may have to be intubated. It just depends, and hopefully we can intubate because they're probably going to have a lot of edema internally. But intravenous fluids, what type of fluids will we use? Isotonic always, lactated Ringer's, normal saline. Nutrition is important. We're checking a pre-albumin probably every morning. They're on a high-calorie diet. Most burn patients, right? High protein, maybe on tube feedings for our children, things like that. Antibiotics, analgesics, and anesthetics. A lot of our children go back to the pediatric intensive care unit, and they have conscious sedation before they have their dressing changes. It's just that serious. Second on up, second, third degree, and they may receive fentanyl and propofol and things like that for their dressing changes. We don't want them to remember those situations and things like that, and a lot of physicians say they really won't. And just depending on the age of the dressing change or none of that, they usually will not remember any of that. They're in the hospital for a long period of time, and they're strictly taking output, daily weight, and so we're just monitoring them closely. Very, 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 very closely. We do have a burn unit in Mobile, and so, but most of our children still come to USA Children's and Women. But our older children, adolescents, and things like that, they'll go to the burn unit, and they're there for a long period of time. I'll check your hand up. Oh, okay. Sorry. Injury prevention, safety. Can't say enough about safety. And that's that one, and that took too long. All right, immediately into hydration. Is it oxygenation?
Oxygenation.
Y'all know oxygenation. Do y'all really need oxygenation? Yeah. Oh, yeah. For children. All right, oxygenation. I'm coming in to set up the room for these clients. So, can I get 3 people up here?
Before you move on, can you tell us what is CAST stand for?
What is what?
CAST stand for?
Cast. Oh, wait. Give me a minute. I have to come back to that, baby. That's for Thursday, right?
Yes.
It's on our syllabus.
It's on your syllabus for today?
Yeah. It's
Child advocacy. I'll just have to get the words. I can't just say it right off. Not like that.
It's in like parentheses next to.
It's Thursday. It's Thursday instead of Friday, cast it. So, It's on your syllabus for today?
Well, y'all changed it.
It's Thursday, so yeah. Okay, so I got a little time.
It's on the syllabus for PCR is what she's saying as an objective.
It's under the syllabus for what?
And under PCR, so she's just trying to figure out exactly what it was. Not necessarily the calendar.
Yeah, I'll get it for you, but I can't holler it out right now. That's just a webinar. That's some information for you to be abreast of. That's not nothing you will be taught on. That's something that we want you to be abreast of about child abuse. So can I get 3 individuals up here to be people for us? Be nurses for us. Not everybody come at one time.
They're close to
All right, we have 3 nurses today that will be taking care of these clients. We have a 3-month-old that Ms. Lou will be taking care of. That came in with RS. We think they have RSV, and that's all I'm going to say to Ms. Lou. And Ms. Tristan, we have a 5-year-old who's been having episodes of tonsillitis and things like that, frequently being treated on oral antibiotics. And now she's coming in to have a tonsillectomy. And then Mrs. Tabitha, she, I won't say you just had a baby, but.
Oh, my baby's 18. Come on now.
All right, she has a 8-year-old who she's been caring for. Well, you're the nurse. You're caring for an 8-year-old with cystic fibrosis. All righty. So, Ms. Lou, can you tell us what do you know? With oxygenation, what are we talking about with our assessment? Just everybody. What are we assessing?
level of consciousness.
Oxygenation.
So she has a 3-month-old that the mom thinks has respiratory syncytial virus. So tell me, how are you going to care for that 3-month-old, Miss Lou, as the nurse? You're coming in, and I wish I had a baby. I wanted to do all that, but just
I'll be your baby, Lou.
Oh my God.
Okay, so
You're coming into the
I'm
room.
going to immediately assess. I guess I'm going to take my vitals. I'm going to assess the respiratory status. So I want to make sure that the respirations are within, they are adequate. And
What makes them adequate?
30, 60.
30 to 60? Okay.
Okay, 30 to
And they're breathing
60.
at like 55 breaths per minute. I mean, 65 breaths per minute.
Okay, well then I would, if the doctor prescribed any type of oxygen.
They're breathing at 65 breaths per minute. And so I have the infant, they're in the crib.
Oxygen in the crib?
They're in the crib. They're coming to the floor. They're being admitted to the pediatric floor. You're the nurse, you're admitting them. So you're coming into the room. So what things are you doing when you say you're assessing them? And so
So I want to make sure that there's nothing in the crib, obviously, that the mom has put in there. So I'm going to check that. I'm going to check for safety. But if they're breathing, after I check the vitals,
They're lying supine.
Then,
They're lying supine.
okay, so elevate. So pick them up.
Elevated to what?
30 to 45.
Uh-huh.
30 to 45.
30 to 45. But I also can use what?
75.
Car seat, right? Place the baby in the car seat, latch it, have the rails up. But I'm concerned about the breathing. They have tachypnea going on, and so what? With respiratory syncytial virus, what things are going on?
And they're struggling to breathe.
Their flu.
You might need to auscultate
They may
their
have
lungs.
Yeah.
Secretions
Secretions.
build up.
secretions on mucus or something like
Thick,
that going on. So,
thick yellow secretions usually.
right, so
Yeah.
I would use the,
Suction.
if it is, I would use my whole, I don't have children, so y'all.
The Voltaren, Is she using the Voltaren?
No?
You would use suction. You would suction the baby?
Nasopharyngeal suctioning for RSV.
Yeah.
So I got the catheter, 6 French, 8 French catheter going out to lubricate it a little bit. Yeah, you can't lubricate it a little bit. I mean, just put it in the saline a little bit and, make sure it's working. So what I am saying, and I may be just doing it a little different, the room should be kind of like set up. I got my suction, pulse oximeter. I might need to know that O2 saturation now because I know I see tachypnea going on. 9 times out of 10, you're going to see other signs and symptoms of distress from the infant, which are the seesaw breathing, what else? Nasal flaring, nares going in and out, what else? Retractions, what kind of retractions?
Chest.
Suprasternal, substernal, intercostal, in the rib area. Cyanosis, someone said. Could be just the acrocyanosis, right? Need to get O2 saturation. O2 saturation probably what?
Probably 93.
Or less.
No,
I said maybe 90, 88%, right?
Mm-hmm.
So what can I do to help this baby right now? I don't even need the doctor.
Oxygen.
Lift them up.
Maybe
Suction
oxygen,
them.
but what else?
Suction.
I don't need the doctor. It's non-pharmacological.
Suctioning.
Suctioning. Suction is the greatest thing for RSV babies. Nasopharyngeal suctioning every 2 hours. Sometimes I get busy in another room. Respiratory can help as well. But nasopharyngeal suctioning. Another thing, if the respiratory rate is greater than 50 breaths per minute, usually we make them what? NPO. They have an increase in work of breathing, so now they can't suck, right?
Yeah.
And so the secretions are, draining in the back of their throat and things like that, and it's choking them, so they can what? Aspirate. Sometimes some physicians said that they may come in wheezing a little bit, just a little bit, so he may put them on some type of albuterol treatment. Older kids, Zopanex, things like that. And he may prophylactically put them on intravenous antibiotics. We will probably start IV fluids on them, right, to hydrate them. And so this is they won't be eating, nothing by mouth, until that respiratory rate comes down. And then what will we probably start with before we start with formula?
Saline waters. No.
By mouth, what will we start with? Probably. Because the thick milk would probably just be a little bit too much for them. So we might give them Pedialyte. So Pedialyte, electrolyte replacement. And so anybody that can come in and probably be dehydrated, you can't get 3-month-old popsicle now. The older kids you can't. So
They have Pedialyte popsicles, so that's what I was thinking about.
so now she has a 5-year-old that has the tonsillectomy that's coming in for the tonsillectomy. How should she set up her room?
Suction, airway, like that.
Do I need a lot of suctioning?
No.
Am I gonna go into that mouth when she come back?
No.
I might. Sometimes, they do have a lot of little secretions in the oral mucosa. You got to be careful. I may have to use. I try not to, but I may have to use the Yunker. But really, no suctioning. We don't put anything into the mouth, right?
Otoscope, so you can look in the back of the throat. Tongue depressors.
Yeah. All of that. Otoscope, you maybe can. Tongue depressor, that's the physician. Because you still, as the nurse, that draws a line. You don't need to, the physician will do that,
You go serve for bleeding.
But definitely.
Assessing your patient like for any infections or anything.
What are you going to hype? So you got your suction maybe set up, maybe the head of the bed elevated right. This is still, they haven't gone to surgery yet. So what kind of
Toys like for them to play with.
she's a 5-year-old, so what am I doing for her? The baby, she was saying, yeah, they're going to have the surgery tomorrow. So what else can you do for the 5-year-old preschool?
Tell her to
Everything's interchangeable.
The doll, right? Magical, things like that. You're going to try to tell as much as you can, You can even say maybe, you can't really just tell she have a bubble on it. She should say, oh, my neck, that was her neck. So I don't know how that doll will demonstrate that she had her tonsils taken out. But just, maybe that you've really been sick a lot, Mary. So you're going to feel so much better in a couple of days, once you have this surgery and things like that, and making sure the doll. And then maybe at that time, she can have something to drink. And maybe he might let her just be on a clear liquid diet, but I can show her some things possibly that she'll be able to have after surgery, right? So that might help her a little bit. I can give her the stickers and things like that, and then I can educate mom. And so what am I going to tell mom? Status post tonsillectomy.
Avoid straws.
Avoid straws, sharp objects, crunchy things, foods. She's going to be on a post-TNA diet, which entails what? Clear liquids. Nothing red. Why?
Because of blood.
Blood. We don't know if she's coughing up blood or what it is, whatever it is, right?
She's on her side.
Frequent swallowing is a great indication of what?
Hemorrhage.
Bleeding. Hemorrhage. Very good. Frequent swallowing is a great indication that there's possibly some bleeding going on. So vital signs and all are going to tell me a whole lot. What else is going to be her number one problem coming back from surgery besides just the bleeding? Pain, discomfort. So the doctor generally has Tylenol with codeine around the clock, every 4 hours. Sometimes he'll let us even in between, for breakthrough pain, give them a little bit of Motrin. But that's the key. But the hardest thing is to get them to swallow the first time after surgery because they said that it hurts. And I believe that it probably does. It's very, very painful. But once they get that fear out, and so what we use, syringes, right? Syringes to draw up medicine, syringes to draw up juice, maybe have a melted popsicle, things like that, and just squirt it in their mouth. And then eventually they get better. But pain is it. Tonsillectomies are mostly done outpatient, but the reason that they have to be admitted because they became dehydrated at home, right?
Yeah, they want to drink a little sucker that is got pain medicine in it to numb the throat.
Do they? They have
That's
that
what
now?
my kids had when they were little.
Really?
Wouldn't you give that pain medicine like IV or rectally because you don't want to do it?
No, she can take something by mouth with the syringe. We don't really want to give children much intravenously. Yeah, they don't need more. She don't need morphine. She don't need. That's just a little bit too strong. Now some physicians may, but I've never encountered that. Well, they did the the minimal. Tylenol with codeine is definitely enough. Yeah, and it takes care of it, really well. If you're on top of it, but then you got to get the child to, swallow and things like that. But once they get that first dose, they're generally okay. They feel much better. Then they start drinking more and this, and things like that. Yeah, it was liquid. Oh, I'm sorry. Yes, liquid. Yeah, liquid Tylenol with codeine. In a little cup, draw it up, about 5 ml. It's a dosage, there. So I think you guys have that.
Priority and that would be like to make sure that the patient is hemorrhaging.
Priority is hemorrhaging, yes, but another problem is pain as well. You want to keep them hydrated, so you want to give them the pain medication. So hydration, but priority, is post-op bleeding. Yeah.
So if they were hemorrhaging, what would we do?
You would notify the physician, and he would probably immediately take them back to surgery.
But like if we're in the room,
It's not too much that you can do besides monitor the amount of blood that they're doing, keep them from, aspirating and things like that, have the head of the bed up, and, you can suction maybe that. Be careful in the oral mucosa, the amount of blood and things like that. But other than that, it's nothing you can do for that internal area. It's nothing that a nurse can do there.
so we just make sure that the
Yeah, but rarely does it happen, but it still occasionally can happen. So that's the main thing there. Cystic fibrosis, what type of disease is that? What type, define cystic fibrosis. It's an inherited what?
Inherited airway change is increased or reduced within the lungs.
Increase within the lungs and everywhere else, right? And then what? Where else?
Airway.
Airway, what else? Small intestines, right? Pancreas, right? They have fatty stools, called that steatorrhea. They have an increased production of mucus in the lungs, right? They lack the pancrease, so they have to take the pancrease medication, capsules every day. Some for toddlers or whatever, you open it up and you can just put the sprinkles in food and spoon feed them. Older kids, they can swallow it. It's a lifelong inherited disease process, right? Pretty much affects Caucasian, blonde, blue eyes, but we did have had an African American young man who had cystic fibrosis and still living. The longevity is much better now due to medications and things like that. They're coming in the hospital most of the time for pneumonia. They pretty much get portacaps, central lines. They have G-tubes, a lot of them, because they need the supplemental feeding. They're very, very malnourished, right? You can diagnose it at birth. The baby will be born with what? A meconium ileus at birth, a great indicator. But we also assess their sweat. So the medical technologists come from the lab and put the sweat band on the arm, leg, and come back in a few hours and see if they sweat and measure that amount of sweat. And so I think greater than 60 milligrams per deciliter is probably indicative of having cystic fibrosis. I know one client they did, but the pulmonologist said that with the pallor, the different barrel chest, clubbed fingers, and things like that. It was an infant, well, 2-3-year-old. He still, the sweat said that, you know, she didn't have enough sweat or it was inconspicuous, but he still said he knew that she had cystic fibrosis. So, you know, he did more tests and things like that, and eventually she was diagnosed with that. That's the main way that you do that. And there it's very, very, you know, debilitating. A lot of money is being spent out, hospitalized a lot, and they're coming in for pneumonia. A lot of times they're on straight reverse isolation, and parents, they want you to do really, really great hand washing, and they don't want nurses coming in with upper respiratory infections and things like that, because they don't want anything transmitted to their child, because they know anything can exacerbate, make that cystic fibrosis worse. So we have the fibrotic areas within the lung, right? And so that's why they have the copious amounts of secretions that pool there in the pancreas and all of that.
Do people with CF, like, they can't be around each other? Do people that
They can be around another CF or.
Because I have two friends from high school, and they were sisters, and they both had it, so they had to like stay away from each other as much as possible.
I'm not sure about that because I know of a sibling, brother, twins, they had it. And I don't know, and even the cystic fibrosis patients, they interact with each other in the hospital and things like that. But now, as long as they're not on isolation and things like that, you know. Okay, we're done with that. Thanks. They helped a little bit, maybe. So anatomy and physiology, infections increase about age 3 to 6 months. Why? Because they have a smaller airway, shorter distance. We've already identified that. We said with the respiratory syncytial virus. Another thing is the whooping cough or pertussis, right? Until they get immunized, then they can develop that. Had one baby, it's just as terrible as the RSV. The whooping cough is, they're aspirating. They're trying to, what it is that the immaturity of the lung field and the immature development of the body, they're still growing and things like that. They cannot cough up and expectorate. So they, swallow. And so that causes respiratory problems for them. And so even with the whooping cough, nasopharyngeal suctioning, things like that, but they're on like an oral antibiotic, erythromycin estolate, that we give them for a number of days for that, and they do better as well. Any one of these conditions, RSV or whooping cough, can put them in an intensive care unit. They can die from it immediately if we do not get the proper care for them. So just be mindful of that as well.
I think the screen is frozen.
There it goes.
So infants younger than 3 months of age have a lower infection rate, higher than older children, presumably because of the protective function of the maternal antibodies. That's what we say. Generally, when a child develops RSV, that's why we want to give the DTaP to the mother, or we encourage her, right, postpartumly to have that, because that kind of protects her newborn baby, right, from developing the whooping cough, unless he's around, another newborn baby that has not been immunized and things like that. So that's one of the reasons that we do that as well. But her antibodies will last, hopefully, up until about 3 months of age. And so immunizations pretty much start about 2 months of age. But if you got an older child that's at home that's sick with a common cold, and that's kind of like how it will affect, just that older child being ill will affect that newborn baby, and that's how they present. And so they develop the respiratory syncytial virus, pretty much prevalent November through March, April. We do have a vaccine out for it, but it's very, very expensive, and we pretty much give it to our preterm babies, or those who already have an underlying disease process that will really probably kill them if they, got that as well. So what are some signs and symptoms that you probably will see? May be absent in infants, right? But signs of infection in 6 months to 3 years: loss of appetite, vomiting, diarrhea, listlessness, abdominal pain, and all of that. They may have some nasal discharge, nasal blockage. We've already talked about the grunting, stridor. We might see with the laryngeal tracheal bronchitis or croup. They have a stridorous cough. You can probably hear them as you walk in the room audibly. You'll see the wheezing with our asthmatics, pretty much. Sore throat might be a frequent complaint in older children, so they're more prone to develop what group B beta streptococcal infection, and have strep throat and things like that. So we want to ease their respiratory effort in any way that we possibly can. Now this kind of like is a baby that's in the neonatal intensive care unit. They kind of like got him on the sideline position. He has an oral gastric tube in for his tube feedings. He has a nasal cannula in, and then she may just be receiving her aerosol treatment there, the older child. So you want to provide rest, manage the nasal secretions, and prevent spread of infections. So other children don't need to come in the room, you know. Another baby don't need to come in the baby room with a sick baby. Respiratory syncytial virus, you're on contact isolation. Whooping cough, pretty much drop the precautions. So hand washing, all of that, very, very important. Want to reduce the fever. Our infants, you know, once they go home, then we, you know, they can be admitted to the hospital. They're just day one, you know, old, only 1 day old. You know, they come to the pediatric floor. They don't go back to the intensive care. To the newborn nursery because they can cause infections for those babies. And so they're now a pediatric patient. So yes, they get acetaminophen and or ibuprofen, and 10 milligrams per kilogram is the dosage for the acetaminophen for body weight. And about 10 milligrams for the, you can do 10 to 15 for the Tylenol, and about 10 milligrams per kilogram for the ibuprofen. We kind of like alternate these. So pretty much the baby who comes in febrile is really receiving something like every 2 hours. And that's pretty much someone who has like a, 101 temp, 100.5 as a newborn baby and things like that. Hydration. Why are infants at higher risk for dehydration?
Their body surface area is whatever it is.
The body surface area is what?
Smaller.
75% water. So when they diarrhea, vomiting, and all, that's why it predisposes them to becoming dehydrated easier. All right. So we have it there: nausea, vomiting, diarrhea there. So we give Pedialytes to our infants, and they have flavored Pedialyte. Pedialyte is an electrolyte replacement that can be done at home, right? And so that helps a whole lot. Gatorade for our older children. Got to replace those electrolytes. Hopefully that child is wanting to eat, the infant is wanting to eat, so they may have to be admitted to the hospital for dehydration. Just won't hold everything down. Still vomiting, dehydration. Vomiting, diarrhea. Like nausea with the older child.
If they're not hydrated, doesn't that thin out like there's secretion?
Yeah, very good. Maybe giving the clear liquids and things like that. That's why even the Pedialyte, at that time is really good. And that's why the Pedialyte is even good when they have a respiratory problem coming out. That's a very good thing that she said, giving the liquids help thin the secretions. And then it might make it easier for them to expectorate and cough them up. And so remember that nutrition is very, very important for our children, but at the same time, it depends on how their respiratory status is at that time. So they may have to be nothing by mouth and on intravenous fluids. So some of our upper respiratory tract infections are what? Nasopharyngitis.
Not that time, H.
Just give me a minute. Nasopharyngitis, common cold. We might do the saline drops. You have the bottle of saline drops available, squirted in the nose. Then sometimes we can just do bulb suctioning. And so what's important about using the bulb syringe?
Not to suck too hard.
Get the air out of it before you put it in your nose.
Yeah.
Well, you want to squeeze it.
You suction the mouth first when the baby is born. Okay? This patient is now going, it's a pediatric patient now.
So it's just the nose.
So now
You're not going to go in their mouth.
what? Nose breather, right?
Yeah.
And so now we suction the nose. You can suction the mouth, if necessary, but immediately we suction in the nose, right? And the saline drops do help a whole lot. Those little pink ampoules that respiratory use to mix the albuterol medication. We try to use those a lot. Sometimes the doctor will just order them their own ocean spray, saline drops as well. And they have a bottle. It just depends on the facility. And that helps a whole lot. Loosen it up, so consumption won't irritate the inside of the nares a whole lot using the bulb syringe. It's very, very good prior to each feeding, right? Because then it helps the baby be able to suck better and things like that.
Okay, so what was important about the suctioning? I missed that. We were talking about it.
No.
Just nose first, that's all you're,
Because
okay.
their nose
Suctioning
breathers
the nose first,
Yeah.
lubricated with the saline drops.
When they're first-
Suction before each feeding. Yeah. All of that's important for you to identify when to suction the baby. Yeah. To know when to suction, to know how to suction. So nasal pharyngitis can be caused by RSV, influenza virus, or parainfluenza virus. Pretty much identifies some of the symptoms there. Fever is common in young children, and older children may have a low-grade fever, which appears early in the course of the illness. Pharyngitis, group A, beta hemolytic streptococcal is the organism that occurs there. Strep throat. Generally a relatively brief illness that, yeah, it can be, but it cannot be in severity from subclinical to severe toxicity. The onset is pretty much abrupt. You're going to have a headache, fever, abdominal pain, especially in small children. Children who experience having the beta hemolytic strep infection of the upper airway are at risk for rheumatic fever. They're at risk for rheumatic fever. And that's very, very important. Also, untreated streptococcal infection can lead to endocarditis. And so that's a major thing there as well. And so risk of complications, they can have rheumatic fever, acute glomerulonephritis, and I'm going to say and endocarditis as well. So that's why, if your child is complaining of a sore throat, don't just try to, usually if you ask them to open their mouth and you look back there, they're very thick, frothy white patches. And then they have a foul odor coming from their mouth that exudes from their mouth. It's kind of indicative of strep. Sometimes they say they have flu-like symptoms. They're aching all over, chills, things like that, high fevers. So you need to have them examined, and you need to make sure you take care of it. Because that's untreated, it's not good.
Do they
So,
get the endocarditis from untreated?
Yeah.
Untreated. Beta hemolytic streptococcal infection. Yeah. Can lead to endocarditis as well. So penicillin, drug of choice. Sometimes they use a bacillin. Bacillins is the choice, and can be an IV injection. For parents that probably just non-compliant, not gonna get a child medicine right, not gonna do it properly, we're gonna see them again. The same thing. And then for some reason, a lot of children who have tonsillitis have a lot of strep throat infections, and that's a lot of reasons why parents say, I'm just so tired of them having the strep throat. Let's get these tonsils out, and then usually they'll do tonsils and adenoids as well.
Okay, so this makes sure I'm clarifying this. So the nasal pharyngitis is like
A common cold.
and then the pharyngitis is called bacteria.
Right.
So the pharyngitis, you'll give antibiotics.
The nasal pharyngitis, you can just kind of like treat it prophylactically. Suction, curse of fluids, just monitor it closely. Sometimes some physicians they still may order a few things, it just depends on the doctor, but if it's viral, antibiotics will never help you. Like even with Tamiflu and influenza, it's viral, but they give it sometimes just to make the parents, I'm just going to give, but, rest, drinking liquids, the time period of it, gets better.
May we have a bathroom break?
Sure.
Yeah,